Thank you very much. I'd also like to echo the kudos and congratulations to Kelly for pushing this agenda along. I think it's amazing how far we've come and where we're going to go. And thank you for the opportunity to update a little bit on what's happening with HIV. So we know that survival for most people with HIV has increased tremendously. It's about 75–85% of the general population overall, with a significant minority essentially having the same long-term survival as the general population. And interestingly enough, there's a little bit of emerging evidence that there's some people with HIV who may have better survival, longer survival in terms of time than the general population. But the reasons for the decreased overall survival has to do with two main sort of areas, if you will. One is the premature development of age-related medical comorbidities, which is not the focus of today's talk, and the other one is the increased risk of early development of what we refer to as traditional geriatric syndromes. So the common comorbidities, again, I just want to quickly run through them that you're aware of them. These tend to occur with the risk of developing them is higher if you have a low nadir CD4 count prior to starting antiretrovirals, usually less than 200, or if you have a poor CD4 recovery on antiretrovirals, if you're plateau CD4, if you will, is less than 500. Now there's some emerging evidence that the ratio of CD4 to CD8, if it's less than 1, that also may put you at risk for these comorbidities, which include non-AIDS defining cancer, liver complications, cardiovascular disease, metabolic complications, bone demineralization, some renal complications, and obviously neurocognitive decline. But more importantly, what's emerging is that we're seeing what we refer to in geriatrics as geriatric syndromes. These are multifactorial conditions which really don't fit into the usual discrete disease categories. It's not cardiovascular disease. It's not osteoporosis. These have multifactorial etiologies, involve multiple organ systems, are often difficult to diagnose, and have very common presentations. The usual sort of geriatric giants that we were talking about include polypharmacy, sensory impairment, impaired mobility associated with falls, cognitive impairment, impaired bowel and bladder function, sarcopenia, which is the medical term for loss of lean mass, and frailty, which is what I want to focus on today. But just to give you a sense for how common these geriatric syndromes are, at the UCSF cohort, when a survey was done just a couple of years ago, frailty was seen in about 10% was reported by 10% of the individuals. Hearing impairment, a sensory problem, abnormal in about 15% of individuals. Falls were reported in a quarter of all of these patients. Now keep in mind, this is a very well followed, medically very well-treated group with an average age at the time of this assessment in the mid-50s. Visual impairment occurred in about 30% of individuals. Depression reported by 40%, and cognitive impairment by over 45% of individuals. So these common geriatric syndromes, these common complaints, we're seen very, very frequently in these individuals who are on average about 15 to 20 years younger in the usual group of geriatric patients where these syndromes are usually reported. So focusing on frailty, what is it? Well, it's a condition which was initially described in the elderly, and I highlight that because that's part of the problem we have in translating information that was initially described in one population to another one. It's really a state of increased vulnerability. If you will, it's the loss of ability to maintain overall homeostasis in response to either biological, psychological, or environmental stressors. The state of vulnerability, the state of frailty, increases the risk that you will develop comorbidities, disability, and overall increased mortality. The biological underpinnings of frailty relate to decreased physiological reserve in multiple organ systems without I don't want to go into the molecular and biologic contributors to this. It's partially associated with aging, but there are other contributors to this decreased physiological reserve, and there's certainly an association with a chronic inflammatory state. And the reason that that's important, I highlighted, because we know that HIV is associated, treated HIV is associated with a chronic inflammatory state, which may increase the development of many of these comorbidities that we're talking about. In the general population, what are the consequences of being frail? Well, there's an increased risk of hospitalization, increased risk of multimorbidity, which is the term referring when an individual has more than 3 individual comorbidities. Obviously, this would include falls in the geriatric setting. And disabilities. What do we mean by disabilities? The inability to perform activities of daily living, getting in and out of bed, taking care of, being able to eat by yourself, being able to walk, are you continent or not? And the other part of disability is the instrumental activities of daily living. Can you prepare your food? Can you do your shopping? Can you do your banking? Can you, those are the instrumental activities of daily living. Frailty is associated with increased risk of malnutrition, loss of independence, the need to go to live in a supervised setting or to have people help you. Increased risk of dementia, cognitive decline is also seen with frailty, and there is an increased risk of overall mortality if you are frail. Now, the problem becomes in how to operationalize, how to diagnose frailty. I thought there were 27, but it turns out I was wrong as I was reading a couple of days ago. There's probably about 35 different metrics out there in how to diagnose frailty. The 2 most common ones are the frailty phenotype developed by Linda Fried at Hopkins originally, she's now at Columbia. And it's a syndrome of poor nutrition, loss of lean mass, overall weakness, and impaired exercise tolerance. The other most common way in which frailty is diagnosed is the Frailty Index, which was developed by Ken Rockwood from Halifax, and it's a state which represents the cumulative effects of multiple health deficits. It doesn't only have to be clinical problems. It can be laboratory abnormalities, it can be psychosocial abnormalities, social isolation, for instance. All of these come together. The more you have, the more likely you are to be frail. I'm going to focus just on the frailty phenotype because that's the most common one that people refer to. But the frailty phenotype and the frailty index are the 2 most common that you'll see in the literature. They don't identify the same individual. There's about an 80% overlap between these 2. And as I said, there are others. The problem is that both the frailty phenotype and the frailty index are rather time-consuming to perform. So are there other easier ones which are simple to do in a clinical setting? And the answer is yes, but the reliability is not that great. Some of the ones that you'll see which are simple, they take about 5 minutes, they're questionnaires, some of them are even self-reported and include the clinical frailty scale, the frail scale, or simple gait speed. I don't want to go into detail on them. I'm just mentioning these names because you may come across them as simple ones which are still being investigated. So the frailty phenotype, the definition includes 5 parameters: weight loss, grip strength, exhaustion, self-reported exhaustion, walking speed, and low activity. These 5 have very specific cut points which determine whether you have one or you don't have one. If you have more than 3 of these, you are considered as being frail. If you have 1 or 2, you are pre-frail, and if you have none, you are non-frail or robust. The interesting thing to keep in mind is that the frailty phenotype, these features of slowness, weakness, and weight loss are actually, there's a very close association with underlying sarcopenia and with depression. The question is, how much of these occur by themselves in the absence of depression and sarcopenia, and that's still being investigated. Okay? How common is this? Well, in the MAX cohort, what this shows that in patients with HIV, 16% were reported to meet the criteria for frailty, which was double what was seen in the matched controls, the HIV-negative individuals. This was a group with a mean age of 60. 16% frailty is seen in the general population when you're above 80. So there was a 20-year difference for the same prevalence of frailty in this group. Okay, and in the Amsterdam cohort, what was shown was that all ages, frailty was more common than in HIV negative. So it occurs not only in older one, there's a greater, the prevalence of frailty is increased with age, but frailty can occur at any age in HIV. So what are some of the clinical findings with frailty? Frailty, as I mentioned, is increased in HIV positive compared to HIV negative. A low nadir CD4 increases the risk of being frail, but not all studies report this. Asymptomatic individuals who are frail are more likely to develop AIDS, and frailty is a dynamic process. You can bounce back between being frail and not being frail. Okay? And frailty is associated with an increased risk of inflammatory markers compared to not being frail, and that's an important contributor to it. So what are the principles of management? We should screen, in the general populations, it's recommended to screen everybody over the age of 70 for frailty. We don't know at what age to start in HIV, possibly 50, but that's still being investigated. The best metric, as I said, is still unknown on how to determine whether frailty is there. In terms of management, I think it's very key that in the general population, referral to a physical activity program is a key component of it, and this obviously will be an increasing part that we are going to show to be important in HIV. Addressing polypharmacy is a key component of this. Looking for reversible causes of fatigue, anemia, depression, low vitamin B12, hypogonadism, hypothyroidism should be considered. Unintentional weight loss should be evaluated, and protein and caloric supplements are recommended, but the proof that they're actually effective is not yet in. Screening for low vitamin D is very common in HIV, and that should be done. There's some suggestion that low vitamin D can lead to muscle weakness and falls. So to summarize, frailty occurs in people living with HIV. It certainly impacts their functional status and quality of life. The tools, the easiest, simple, and most reliable tools to identify frailty remain under investigation, and principles of managing frailty in the general population can be translated and adopted in people living with HIV, but the exact details is what we're going to help to figure out. Thank you very much.
Thank you, Julian.